So, how we are managing caster-related thrombosis? Actually, you got to know what's the caster-related thrombosis. What do we need the central venous casters for? As a matter of fact, we have the central venous casters for so many patients, like those with cancer, for chemotherapy, for hemodialysis, patients with fluid therapy, TPN, or sometimes for antibiotic therapy, or sometimes for blood sampling. And by location, we have the central venous casters in the majority of the critically ill patients in the ICU, and 25% of the patients in the non-intensive care units who are hospitalized, and many of the outpatient individuals for IV fluid and antibiotic chemotherapy or blood sampling. Looking at the pathophysiology of the caster-related thrombosis, we will find three issues. The first is the fibrin sleeve or the pericaster sheath. Second is the thrombosis inside the caster itself. And the third is the mural thrombus inside the vein. How we get the pericaster sheath or the fibrin sleeve? At the time of introduction of the sheath at the injury site into the central vein, you will induce trauma, and this trauma will end up with activation of the endothelium, and this will start a kind of fibrin ingrowth of the endothelium and smooth muscle cells that will form a sheath, fibrin sheath, all the way down along the whole length of the caster. And this sheath is further activated by movement of the caster, movement during suction, movement during infusion, movement of the patient from side to side. This will further induce injury of the endothelium at the tip of the caster, and later on will induce more fibrosis, forming the pericaster sheath, in addition to reduction of the flow inside the vein by around 60%, which further activates the formation of a process of fibrin deposition around the caster. Second thing is the formation of a thrombus inside the lumen of the caster, and this thrombus comes from lack of anticoagulation at the end of every session of using this caster. And by formation of a small thrombus inside the caster, it proceeds till the tip of the caster, and sometimes it causes what we call a phenomenon of ball valve action. So all of us will find for the patients, when you put a central venous caster for hemodialysis, they call you and they ask you because it gives a good inflow but doesn't withdraw, or the other. That's because the ball valve action of a thrombus at the tip of the caster, it allows infusion because it is by pressure, but it prevents suction. The other thing is the formation of a mural thrombus inside the vein, and this is induced by the injury of the endothelium, and this forms a thrombus around the caster tip between the caster and the vein wall. So in majority of the cases, we will find that it is an asymptomatic form, which is a caster-related thrombosis. In the majority, it is asymptomatic, and it's only been discovered by venography in 41% of the cases. On the other hand, by ultrasound in 19% of the cases. And the highest incidence is in the first 10 days, because the incidence of thrombosis from the time of caster application, the highest incidence of thrombosis is in the first 10 days, and it is being figured in 53% of the cases, while 3% only were occlusive. And the majority of the asymptomatic remain in a subclinical form, because the patients never symptomatize, and symptoms only develop in 1 to 5% of the cases. This is for a central venous caster. But what about the peripherally inserted casters and the vascular implants? The incidence for the peripherally inserted casters is much higher than the incidence of the central venous caster. And also the implanted comes the least for the incidence of caster-related thrombosis. So we have a sequence of orders of the highest incidence in the peripherally inserted one, Why it is the highest incidence of thrombosis? Because of the long length of the catheter, the difference or the discrepancy between the size of the catheter and the size of the vein in the arm that you applied. And the third thing is the higher mobility for the peripherally inserted catheter because of the arm movement rather than the centrally inserted catheter at the jugular or the subclavia. So we have a sequence of higher incidence of thrombosis at the peripherally inserted more than the centrally inserted, and the least is the implants which we put as the portacast for the patients with chemotherapy. What are the risk factors of thrombosis? We have three relations. The first is the patient himself with a risk of thrombosis. The second is the catheter related, and the third is the insertion site related. So we can summarize as a global information about the catheter-related thrombosis. We will find the smaller the catheter, the less the incidence of thrombosis. The single lumen is better than the multiple lumen. When you put a small sheath like 3 French, 4 French is better than using a higher French sheath like 7, because the trauma at the site of puncture of the vein is of great impact on the development of the thrombosis. Things which are more important also, the discrepancy is the size of the catheter in relation to the size of the vein. So when you select a basilic vein, it is better than the cephalic vein. And when you use a brachial vein, it is better because the size of the vein is quite enough for adoption of the catheter. One more thing is about the timing of detection of the thrombosis. If you try to catch the thrombosis very early in the first day, 10 days, it would be better than to detect the thrombosis later on. And one more thing is the location of the tip of the catheter, because we use it to teach our juniors. Put the catheter tip at the end of the superior vena cava, just above the right atrium. And if you are doing it on a fluoroscopy, put it at the level of the 5th and the 6th rib in the posterior position. This is the actual location, and you can judge this by something else, is the division of the right main bronchus. If you can see it, the right main bronchus overlapping with the 6th intercostal space, this is the actual location of the tip of the catheter. If you put it at this, you minimize the incidence of thrombosis. If you put it at proximal level into the superior vena cava and the proximal third of the superior vena cava, the incidence of thrombosis goes higher. So this is the catheter-related thrombosis. For the patient, the most important thing is the previous catheter-related thrombosis. So an even to previous catheter thrombosis is the highest incidence of recurrence of the catheter, and second thing is a previous catheter central venous catheter inserted. Manifestations of the patients are mainly a localized tenderness or edema or pain in the arm. Sometimes we'll find with a large vessel occlusion like the innominate or the subclavian, we will find extensive edema of one side or both sides of the face of the neck, or you will find a visible collaterals in the chest wall. And the other thing is when a large vein is affected, you may find a difficulty or the malfunction of the catheter, aspiration or withdrawal or difficulties. Sometimes you ask the patient, change the limbs, put the red one into the suction and reverse with the venous one. And last thing, and the worst thing, you will find infection at the site of the catheter. So what is the sequelae of the catheter-related thrombosis? One of three things would happen. First is the development of symptoms, which is less than the asymptomatic. The majorities are asymptomatic. The second thing is the development of pulmonary embolism, which is a very important issue. And the last thing is the catheter malfunction. The most important is the pulmonary embolism. Actually, do we have a pulmonary embolism with catheter-related thrombosis? And the answer is no. This is very surprising, because in most of the studies that have been done over more than 4,000 patients in a meta-analysis of catheter-related thrombosis, they didn't find a single case of pulmonary embolism. Some other meta-analysis cases in 12 studies of 252 patients with catheter-related thrombosis, they didn't find a pulmonary embolism. So we can simply answer that question for the nephrologist. Is this catheter gonna give the patient a pulmonary embolism? And most of the articles say no pulmonary embolism for the catheter-related thrombosis. So how we can investigate the patient with the castor-related thrombosis? First, we got to emphasize on the project, you don't have to screen all the patients with asymptomatic castor-related thrombosis just because of the presence of mild symptoms or asymptomatic. You don't have to screen them. You don't have to investigate them. That's why, because the majority are asymptomatic, the majority respond very well to medical treatment. So you don't have to bother yourself and bother the patient by screening the patients. The other thing is the patients with castor-related thrombosis, if there is a physical examination, the physical examination or the clinical input is of limited value because it is neither sensitive and nor it's specific. So what is the specific? If you have a great clinical suspicion, it is the compression duplex ultrasound. This is the best way with high sensitivity and high specificity. But if the clinical suspicion is high and the duplex is still not giving you the best answer, as you can see here, there is an echogenicity and hyperechoic and hypoechoic areas in the castor site, but at this time, you may need to do a venography, MRV, or you can do a CTV if you have a high clinical suspicion without clinical symptoms. What is the role of the castor-related thrombosis management? What do we need to do? First is to reduce the symptoms if we have a symptom. Second is prevention of extension of the thrombosis into a more central veins and into the cerebral venous sinuses. And the last thing is to prevent the chronic venous occlusion as we see in the patients with venous hypertension for hemodialysis. The other thing is the issue to consider. However, we need to do a thrombolytic therapy and keep the castor in place, or to do a removal of the castor and replacement, because in the most of the cases we have a good response with medical treatment and none of the patients would need to remove the castor, or they may not to need the thrombolytic therapy. So if we opted to do the thrombolytic therapy, first you have to exclude any mechanical cause like kinking of the castor. This is number one. Avoid doing thrombolytic therapy in a kinked castor. The second thing is it's very simple. You can use altiplase or tenecteplase 2 milligram injected by instillation into the castor over 2 minutes to 2 hours. This would allow removal and ablation of around 80 to 90% of the thrombus load in this area. So it's only 2 milligram over 2 hours will clear 90% in most of the studies. So indication of the thrombolytic therapy with the presence of intrathoracic major vessel occlusion, or you still need the presence of the castor, like for those for hemodialysis, for chemotherapy, or for TPN. Is there another site for medical treatment in the castor-related thrombosis, like using low molecular weight and vitamin K antagonist? The answer is yes. In many trials, they have tried it for 3 months, and they have the functioning castor in 57% of the cases, and only 5% developed active bleeding. And lastly, no new event of vascular-related thrombosis has happened. DOACs have never been tried in the treatment of castor-related thrombosis so far in the articles. What we need to consider for the continued treatment, for how long you got to treat these patients. First thing you got to know is that the castor-related thrombosis is related to the castor. So the risk of thrombosis is there as long as the catheter is there. Removal of the castor doesn't reduce the risk of thrombosis unless you keep on the anticoagulation. This is the second point. The third point is that the castor-related thrombosis is the most important factor for recurrence of thrombosis in the great vessels. So what is the ACCP guidelines for this treatment? You can treat the patient with castor-related thrombosis by anticoagulation for around 3 months if the castor is removed, and for a longer duration if the caster is still there. Can we prevent the caster-related thrombosis? Yes. First, you have to choose your caster. As a risk factor, you choose the smallest size of the caster, the smallest size of the sheath, a single lumen better than multiple lumens, and you got to put the caster positioned very well near the right atrium, and every single item that we have considered in the caster-related thrombosis, you have to avoid. The second thing, do we have a rule for thromboprophylaxis as anticoagulation? And the answer is yes. Thromboprophylaxis is very effective both in symptomatic and asymptomatic cases of anticoagulation. The other thing is we got to know that none of the anticoagulants have been tried in the peripherally inserted central casters. None of the DWACs have been tried in the central related caster thrombosis. And the anticoagulation doesn't prevent infection. So the things that we are doing, injecting heparin all the time to reduce the risk of thrombosis, this is a total fallacy. The summary of what I am saying is that patients with central venous caster don't have to be screened as long as they are asymptomatic. The second thing, leave the caster in place. You only remove the caster if it is malfunctioning. You remove it if there is a caster-related infection, and you remove it if it is no longer required. So don't hurry toward the removal of the caster just because of the radiologist just told you that there is a caster-related thrombosis. Patients with superficial thrombophlebitis related to the caster are managed by 50% of the anticoagulation of low molecular weight as the usual way. For the duration of the caster as it is there, keep the anticoagulation. If the caster is removed, an arbitrary 2 weeks of treatment of the anticoagulation is continued. If you have a deep vein thrombosis inside a large vein, the only treatment is like the provoked DVT elsewhere. Keep anticoagulation for 3 months and for a longer duration if the caster is still there. In my opinion, and I am using it nowadays, in a non-malignant patient with caster-related thrombosis, I'm using a usual dose of anticoagulation, even in the patients with renal failure, but with a judged and moderated dose, and I keep it as long as the caster is there. Thank you very much.